Katie. I'm super excited to be here today and share about the work that we're accomplishing at the Pennsylvania Office of Rural Health with the same grant that the ARC of Pennsylvania and Temple University have, although ours is being used a little bit differently. All right, so as Katie mentioned, I work for the Health Initiative for Rural Pennsylvania. I'm a nurse by background, and we started our project around a similar time to the ARC with the same grant funds from the Pennsylvania Department of Health. And so I'm going to talk a bit about what we're doing, how it's going, and all of the things that we're learning along the way. I'm trying to get through everything in about 30 minutes this morning. And so I'm hoping we'll have about 15 minutes for some questions and answers, as well as some feedback that would be really wonderful for us to have from you all. So the Pennsylvania Office of Rural Health is one of 50 state offices of rural health. Every state has one. They are most typically situated with the state health department, but in 10 states, including Pennsylvania, they are situated in a university, and we are part of Penn State University at the University Park campus. Our mission is to enhance the health status of rural Pennsylvanians and make sure they have access to high quality, affordable health care. We are not at the direct service level. We're more at the coordination, professional development, quality assurance, technical assistance, and partnership development level. We have a number of staff, probably about maybe 8 or 9 staff that work in the Pennsylvania Office of Rural Health that work on a number of different grant initiatives. So when we talk about COVID-19 and health disparities, the CDC Health Disparities Grant Program that Pennsylvania received through the Pennsylvania Department of Health, many other states also received this funding. The health disparity that we're particularly working on is people who live in rural counties. For those of you that don't know, Pennsylvania is mostly rural. 48 of our counties are considered rural by the Center for Rural Pennsylvania. And so that is the health disparity that we are particularly trying to address with our work. So with COVID-19, there is a rural-urban divide, both in Pennsylvania and across the country currently. COVID-19, the death rate is 1.3 times higher in rural counties than it is in urban counties in Pennsylvania. In other states, we've seen that number be sometimes as high as twice as much. So it's a little lower in Pennsylvania, but still more than what we're seeing in urban counties. 4 out of 5 counties with the highest incidence of COVID-19 are rural at the moment. I just checked that this morning. 9 out of 10 Pennsylvania counties with the lowest vaccination rates are rural. We see in the top 10 that are highest vaccination rates in Pennsylvania that most of those counties are urban counties. Just to give you an idea of what kind of vaccination rates are we talking about, it's anywhere from 32 to 46% in the lowest 10 vaccination rate counties that are rural counties here in Pennsylvania. The lowest is currently Fulton County, which sits at 32% fully vaccinated for everyone age 5 and older. We're also seeing, although not right now, now that the pandemic is in sort of a lull or a lower state, if you will, with less cases, hospital capacity has been returning more to normal. Hospitals are generally having a terrible time with staffing shortages and people, generally being really burned out in those settings. During the last height in the pandemic with the Omicron variant, we saw in rural Pennsylvania very diminished hospital capacity, many times with zero capacity to serve patients that needed treatment for COVID-19. This graph is from a recent MMWR article. It just shows the gap in COVID-19 vaccination coverage between rural and urban areas across the country. Since April of 2021, the gap has more than doubled, as you can see over the right-hand side of the screen there, with rural counties being about 59% fully vaccinated across the country versus 75% fully vaccinated in urban counties. This is a very busy slide. I hope you can read some of it here. This comes from the CDC COVID-19 data tracker, and it shows vaccine status and intent among adults age 18 plus. So this does not include any of our pediatric, our kiddos basically. Overall, across the country, the vaccination rate is roughly 86%. That does include, you'll see that kind of lighter blue group there that is definitely will get vaccinated. And so that number is quite a bit higher than what we see in Pennsylvania in general. Pennsylvania's fully vaccinated rate has been more in the 60% range over time. However, that includes everyone who's age 5 and older, not just 18 and older. If you look at 18 and older statistics in Pennsylvania, those are higher. Overall, we see that the least vaccinated population in rural counties is children ages 5 to 12 or in that 12 to 17 age range in general. The important thing about this is that it shows vaccine intent across a number of different demographics and rural and urban characteristics. And the sky blue bars, what I call it, the 3.5% that will probably get vaccinated or are unsure, is what typically is referred to as the movable middle, or folks that may still get vaccinated if reached in the right way. You'll notice at the very bottom center of the screen there that the vaccination intent across rural and urban counties, or the difference there, that sky blue bar is about the same now as it has been, it hasn't been in the past. The rural bar for people who were the movable middle used to be a bit larger, but we're seeing quite a bit of narrowing over time. Also, you'll see that that orange bar, folks that will probably or definitely not get vaccinated, is larger in rural areas than it is in urban areas. Overall, what we're hearing generally in the community is that everyone who wants to be vaccinated has been vaccinated at this point. And you know, the opportunity for vaccination clinics, unless they are kind of reinvented or reinvigorated or incentivized in some different way, are not likely to be well attended in rural settings. So the Health Initiative for Rural Pennsylvania was established by the Pennsylvania Office of Rural Health with our Department of Health grant. Our period is June 2021 through May of 2023, very similar to yours with the ARC. Our short-term objectives are to reduce the incidence of COVID-19, increase the vaccination rate, and then more recently, given where we are with the pandemic currently and the community feedback we're receiving, we've started to sort of pivot some of our efforts to focus a bit more on pandemic preparedness for future waves and pandemic recovery, both in mental health and economic standpoints. These are our grant deliverables, each of the 3 wheels here. So we'll start with the messaging wheel. We are currently working on a rural-specific mass marketing or education and outreach type campaign. It is currently being tested not through focus group, but through survey. We anticipate that we'll be ready to launch that campaign within the next 30 days or so. However, we're meeting with those folks actually just after this meeting today to discuss how we're going to roll that out and the timing of doing so, given the current sort of tide with COVID, the cases being really down. I think the community appetite being somewhat diminished right now for additional education and other activities. We are also engaging in some research. I should probably call that more program evaluation at this point, but that includes rapid community assessments, focus groups, key informant interviews, and surveys with rural Pennsylvania residents or rural health, rural organizations, maybe not just healthcare related, but organizations in general. We have completed the rapid community assessments, which I'll share the results to here in a few. And we've also completed the first round of key informant interviews and are currently putting together a summary of those findings. We are also engaging in community development, and I will talk much more in depth about what that looks like. But we have developed 20 cross-sector community advisory groups for COVID-19 in 20 different rural counties. We have also developed a rural Pennsylvania COVID-19 learning collaborative. It sounds very fancy. It's really not. It's just a Microsoft group where we have everyone from all of our advisory groups included, and we share a lot of information there. There is an opportunity to email everyone, but we also put all of the documents and resources and things that are helpful to our folks there in the Learning Collaborative. And then also there are 5 counties in Pennsylvania, rural counties, that have high vaccination rates. And we have been reaching out to those counties to find out what happened there, what can we learn from that, and how might we implement that in other counties that are struggling. Our program can also provide local funding to these 20 counties or other rural counties in general to carry out the work that we're promoting. So here is a map of the rural counties that are at highest risk for COVID-19. You'll notice the counties highlighted in yellow are those who were at highest risk, kind of in the top 10 list of highest risk counties. Those highlighted in blue are those that were in the sort of second set of high risk counties, 11 to 20. Like I said, we have engaged or started to engage in a community development process in all 20 of these counties at this point in time. So when I mentioned we have formed advisory groups, now 20 of them, these are the sorts of folks that create that cross-sector membership that we've been looking for in the community. So we have representation typically from a number of different healthcare organizations, local pharmacies. We also include county commissioners or other elected officials when they're interested or available. We've seen really actually pretty good attendance from our government officials to our advisory group meetings in the past and participation in the activities, but that is not the case in every county. We have seen quite a few school superintendents be part of our work from K through 12 school districts, colleges and universities, chambers of commerce, all the sort of business and industry sorts of partners, emergency management offices. You can sort of see the whole list here. The Department of Health does have COVID-19 nurses typically that are stationed in each county and sort of regional supervisors. They have also hired a group of community health organizers, or still hiring them actually, with this funding also. And those folks are meant to assist with vaccination clinics and other vaccination efforts in counties, sometimes one county or multiple counties at a time. And they are also working to address social determinants of health at the local level. And then we have, partnership typically from faith-based organizations, community action agencies. We did have our first member from a local ARC chapter join just this past week. And I'll be reaching out to you for some additional feedback on how better to involve folks from ARCs, local ARCs, and other representatives that may be helpful in our efforts as we move forward. This is the community development process that we have implemented in the counties that we've been working in and forming these advisory groups in. So we do a community needs assessment, problem identification and prioritization, and then we move on to action or intervention planning and implementation. As I mentioned before, we have been able to support the implementation of the action plans that are developed locally through our funding from the Department of Health. This is our progress to date. We have developed or convened advisory groups in 16 rural counties. And then in some of our counties, they already had some kind of similar group that was meeting. Sometimes it was COVID-19 related, sometimes it was more broadly healthcare related. Sometimes it was more business and industry related. And so we have either merged or restarted sometimes these COVID-19 task forces in 4 counties. In general, what we saw is that in rural Pennsylvania, there is a significant lack of infrastructure in order to support this work in general. And so we really developed these advisory groups from the ground up and have started to engage in this work in a more grassroots approach than I think may have happened should we not have been there or not have this funding to support these activities. We finalized 10 community action or implementation plans. We are formalizing that action through a charter document in each county with some identified roles with leadership. As I mentioned, we have done the COVID-19 Learning Collaborative. It currently includes 211 members across rural Pennsylvania. We've compiled and shared local best practices and lessons learned, and I will be sharing those in just a moment. We've developed the Rural COVID-19 Promising Practices Awards Program, and we've engaged in some research as well as that marketing campaign. As far as our early success, we're seeing overall the biggest success we've had so far is in Warren County, where we have successfully moved the vaccination rate from 40 to 48% fully vaccinated. In Mifflin, Union, and Venango counties, we're seeing 1 to 2 percentage points of increase there, also early on in our efforts. I would say at this point, we have probably 2 or 3 counties that are really starting to actively implement their action plans, and the others are all in various stages of planning those or just sort of jumping off into the action phase from the more data and planning phase. So what we've learned so far, I'll be talking about the rapid community assessments that we did in the fall and the results to those. I'll share sort of an overall view of the problem identification work that we've done in most of those 20 counties at this point. Our learning collaborative results from counties that have high vaccination rates, as well as local feedback that's more RCA Rapid Community Assessment is what that stands for. We did a process in the fall that included 69 folks from across rural Pennsylvania, 13 rural counties. And it was just, it was not a formalized research, I should say. It was a snowball method. We kind of went out into a number of counties and talked to people in public places, whether it was sort of a downtown area, a park, anywhere where people were out and about in some sort of public setting. And we asked several questions around current feelings about the pandemic, as well as reasons for vaccine hesitancy. These are the top reasons that we found in rural Pennsylvania for vaccine hesitancy, which include increased levels of myths and mis and disinformation, perceived immunity from prior infection. That is a key issue. There also seem to be some interesting sentiments around herd immunity and what that means, and whether that means that folks should not get vaccinated. Lots of inputs around things being politically charged or motivated, distrust of government, expressions of freedom and personal choice are very common in rural Pennsylvania. We see this sense of rugged individualism that's very common, where people really don't want to be told what to do, and they don't necessarily trust the government telling them to do so. There's sentiments in rural Pennsylvania that this is an urban-only issue. This is COVID-19 only happens in big cities and not in rural areas, which we know is couldn't be farther from the truth, but the perception is definitely out there. Then lack of reliable, consistent information. With the change in news sources over time, this is definitely an issue that has come about more so probably in rural areas than in urban areas. But most folks are getting their news and learning information from Facebook or other social media outlets, which we know may or may not be spreading correct information about COVID-19. And then ingredients in vaccines is another key thing that we've heard. We've heard everything from the vaccine changes your DNA to it has microchips in it, to from the more religious communities that it's the mark of the beast. And so lots of different things that are floating around out there as reasons for vaccine hesitancy. So common problems across counties. So as we've engaged in this problem identification and prioritization work in the 20 counties so far, this is a list of problems that are common across counties or things that we hear in more than one place. So disinformation is huge. Lack of local endorsement, local infrastructure, and local storytelling. So we see lots of outside influences happening in the counties in general, but we're not seeing a lot of local leadership sometimes sort of taking a stand or endorsing vaccination or other COVID-19 mitigation strategies. As I mentioned, some of our counties were really lacking in that local infrastructure to be able to support this work. And we don't see a lot of local storytelling from people who are recognizable in the counties or that other people probably know at this point. And that's something we're working to address. Reduced demand for vaccination, like I said before, we're hearing this a lot more recently. Everyone who wants to be vaccinated has been vaccinated. There are certainly pockets of folks that may be experiencing disparities or barriers to care that are not enabling them to be vaccinated, even though they would like to be. But those pockets are becoming fewer and far between. Lack of resilience. People are tired of this. I'm tired of this. I have to say, my children went to school for the first time and didn't wear a mask in 2 years last week. And we're located here in State College, Pennsylvania. So in rural areas, we see that schools in general have gone to mask optional for quite some period of time in general. But people are tired of it. And now that we're in this sort of lull in the pandemic with reduced cases, I think it's providing some welcome relief, but also moving people into a place where the preparedness for future waves may be a real challenge. High levels of vaccine hesitancy and dug in thinking, sense of, we talked about that. It's kind of negative out there. We hear a lot of negativity, lack of compliance with mitigation in general. You'll notice if you go out to some stores, let's say in rural Pennsylvania County versus perhaps in Philadelphia County, maybe not so much right now, but during the height of the recent wave with the Omicron variant, nobody's wearing a mask in rural Pennsylvania, and in urban settings, you'll see definitely more people wearing masks. Altered perceptions of risk, political and faith-based influences. So, we see in most of rural Pennsylvania is typically the majority is Republican voters. There is a relationship between being a Republican and having higher levels of vaccine hesitancy in general. And so we're kind of buttoned up against some of the political influences that are moving things in the opposite direction. Faith-based influences can be really good or really challenging, depending on, what sort of information is being spread through churches. Overwhelmed healthcare systems and unrealistic expectations for healthcare access. When we saw diminished hospital capacity with the most recent wave and the Omicron variant, people really there was a definite disconnect between the fact that the hospital didn't really have capacity to treat people locally, and people assuming that if I get sick, I can just go to the hospital and show up and be seen right away and it should be fine. There seemed to be a major disconnect there where the community had sort of no idea what was going on in the hospital systems. Mixed perceptions and implementation in schools, businesses, faith-based organizations. We see everything all over the map and how vaccination and other mitigation strategies are being implemented in these types of settings. Inconsistent, hard to use data sources. So there's differences between the Department of Health data, the CDC data, other forms of data, and for a local resident, it's really hard to navigate like which data is the right data. How do I even find this data? How do I know if COVID is even bad in my county currently? Equity and access issues we talked about, and inability to isolate or quarantine. So that's a key issue. Lots of folks are not able to stay home from a financial standpoint or other standpoint. This, of course, is not quite as prominent right now that we're in a lower phase of the pandemic. But in general, this was something that was very hard for folks. And often, so sick people are going to work or sick children are going to school because there is not capacity in the family in order to keep people home during an isolation or quarantine period. Local mandates are hard to enforce. The way that government systems are set up in Pennsylvania, local ordinances are hard to implement and enforce. There are some counties that have had better success with this than others, but in general, it's very hard to implement and enforce at the local level. Best practices and lessons learned. So this came from our work with the Learning Collaborative and talking to folks in those counties that have high vaccination rates that are rural. And so there's 4 main areas. The first is education and outreach. And so when counties are engaging in a lot of local storytelling, local recognizable faces, trusted messenger programs, and when their political leadership has come out with local endorsement or even local physicians or folks that are recognizable in leadership capacities, that does really seem to work. Addressing specific mis and disinformation that's out there. We see great success with counties who have developed or enhanced local information hubs, whether it's a website, a Facebook group, or some other type of platform that houses local information about COVID-19. Right, so it's pretty negative out there. We have seen good success with counties who have offered some sort of stage debate, town hall meetings. I know you all have engaged in some listening tours, which can be helpful, educational workshops. Be really careful about these sort of publicly engaging events because they can really turn negative if you're not careful about the way that you set them up. But that does seem to be one method that's being used to sort of counter some of the negativity that's out there. Warrenvax.com is a really great local information hub, a great example of something that's been recently developed and implemented. Trusted messenger programs in schools, churches, businesses, or other local venues. So we see great examples of this in schools with the Philly Teen Vax Ambassador Program. That is a student-led vaccine ambassador program in the Philadelphia School District. In churches, there's a church in Union County that has a 90% vaccination rate amongst their congregation, mostly due to the fact that one of their members is a local pharmacist, and he brings vaccination into the church on a regular basis, along with some educational messaging, and that has been very helpful. Also with large businesses, so Procter & Gamble is a great example of this, where they implemented mandates for employees to be vaccinated, despite the fact that the OSHA mandate sort of never went through. Some local businesses did do that. I would say at this point, though, I don't think mandates are really the answer any longer. I think that even the discussion in rural areas early on around the OSHA mandate really pushed a lot of people in the wrong direction and made people feel like they were being forced to do something that they didn't want to do, which I think only sort of brought about higher levels of that real hesitant and dug-in thinking around vaccination. So I wouldn't necessarily say that mandates are the right thing anymore. We saw a lot of early success with mandates in some of these counties, but I think more of a tailored programming approach that you'll see here is a better option at this point in the pandemic than implementing a mandate. Other best practices and lessons learned, accessibility of vaccines, testing, and other mitigation strategies. Again, I mentioned before that vaccination clinics would at this point need to be sort of reinvented or incentivized or look really different compared to opportunities that have been offered in the past to bring about more folks that want to be vaccinated. They're just not well attended anymore unless they look a little bit different, especially in rural settings. Home test kit distribution. There's a lot of really great programs out there where folks can now get home test kits ordered to their home. There's a federal program where you can get 4 sent to you for free. And then the Pennsylvania Department of Health have also recently implemented a program where any local organization can sign up to be a home test kit distributor in their county and order a certain amount of tests. Mitigation stations. So mitigation stations or sort of giveaway baskets, we're seeing some help with. So that's when you like walk into a place and you notice they have like a little stand that has hand sanitizer and masks, and people aren't wearing those and doing that thing right now. But, you know, for the next wave, it's nice to potentially have those in place and available, and people understand that they can choose to use those things as needed. We also see some success around less intrusive mitigation in general. So mitigation that happens where people don't necessarily know about it, or it's not as noticeable. So for example, air filtration systems down in Somerset County, one of the local school districts there, manufactured Corsi air filters. They had students actually build these. They bought, they were about $50 a piece to produce. And that air filtration system was put into classrooms to reduce the incidence of COVID-19 and was very successful. Tailored programming and toolkits, and then equity issues that vary from place to place, but do need to be thought about and addressed. Local feedback. So I mentioned reduced vaccine demand, case counts are down, people are tired. I have been in healthcare for 20 years now, and I have never had any sort of health thing that I've been involved with that was political or faith-based. So COVID-19 has been a learning experience for me, and I'm sure many of my colleagues who just haven't addressed this sort of thing before. But local politics really play into how successful we are likely to be in implementing our action plans in rural Pennsylvania. Potential pivots, as I mentioned, especially at this point in the pandemic, more focus around pandemic recovery and pandemic preparedness for future waves. And that pandemic recovery, more of a focus on mental health and local mental health supports is something we're seeing, as well as some of the economic components that have been really challenging over time with inflation and businesses closing and staffing shortages and all the other components that went on early up in the pandemic that are not yet remedied. So that's the end of my presentation there. And I think one question I have for you all is how can we better incorporate the needs of people with disabilities into our process? We had one, as I mentioned, one local ARC chapter person join one of our groups recently, but in general, we haven't seen a lot of collaboration between our program and some of the local programs that would be able to help us with some of this work and make sure that the needs of folks with disabilities are very much at the forefront of the work that we're trying to accomplish. I'm going to stop sharing and also ask if there are any questions.
Rachel, we didn't see any come into the chat, but I am going to give it another minute or two here to see if anyone does have any questions. Thank you so much for your presentation. Very informative about what's going on in our rural counties here in Pennsylvania. So everyone, I'll give it another minute here. And while we're doing that, if Tay and Kim want to begin transitioning in for their presentation, that'd be great. Rachel, there is a question. Can you say more about faith-based outreach and what that's meant for your project?
Yes, absolutely. So in most of our advisory groups, we do have a pastor or reverend that have joined the groups. Oftentimes they actually take on the chair position in our local advisory groups, which is really nice to see. But we are currently working on developing a faith-based toolkit for churches. So those would include all different types of strategies and sort of a menu of options that churches could choose to implement or not implement, depending on, you know, sort of their situation and climate among their congregation. So like I mentioned, a faith-based toolkit where churches can choose what works best for them if they would like to implement. Also, if some of our faith-based leaders are able to move into churches and have a chance to provide some sort of educational workshop, vaccine opportunity, or other discussion around, future pandemic preparedness or mental health. How can we get the faith-based toolkit? Great question. It's currently in development. We have a contact over at the Department of Health that we've been working with to help us create this. This is one of her main roles. And it's in development. I think it'll be ready for release here in the next probably 30 days.
Thank you, Rachel. Just want to double check to see if this was another question. In terms of the outreach to persons with disability and intentionality, and having persons say they felt invisible or an afterthought is a major out. So that wasn't a question, it was just a comment. But
yeah, that's why I'd really welcome some feedback from you all on how can we better incorporate the needs of folks with disabilities into our work in rural Pennsylvania. Because so far, I would agree that it feels sort of invisible. In your faith-based outreach, did you work more with the connected faith-based systems, such as Presbyterian University, Methodist Conference, and districts? Sometimes. Sometimes we have connected with some of those folks, but can you provide a bit more feedback on how that might be helpful? Are there any persons for involvement of persons with disabilities, are there any persons with disabilities on local groups? No, there are not currently. Like I mentioned, we only have in one county, the local ARC chapter president has joined, but otherwise we're not seeing a lot of collaboration, and I'm not quite sure how best to reach out. If we were to have someone with disabilities join an advisory group, how might we find such a contact?
I can probably answer that a little bit. I think if you do want to outreach, if we can connect our local chapters who are participating and get them, because they are definitely the hands and feet on the ground in those local counties and might know of self-advocates that would like to participate. So that I'll make a note of that for Nancy and Sherry that was raised.
Great. I also saw a comment from Perry about the Centers for Independent Living can be another resource. Thank you.
Alrighty, everyone. Any final questions for Rachel? Rachel, I believe that's in referring to your question about the presbyters and the United Methodist Conference. So Sally Jo was just giving you that further information.
Great, thank you, Sally.
Alrighty, Rachel, thank you so much for your time here today. We really, really appreciate it.
Thank you for having me.
So now I'm going to go ahead and invite Tay and Kim to go ahead and turn on their screens, because they are going to do the Temple University Inclusive Health Equity Collaborative presentation.
Thank you so much. And it was great to be able to hear about Rachel's work and how our work, it sounds like we need to be working even closer together than we currently are. And sort of a lot of the opportunities and lessons learned. We have a lot of information about our work as well under this same funding opportunity, and hopefully do a bit of a deep dive into some of the work that we've currently been doing. Kim will talk about that. But I just hope I'm going to start with jumping in and sort of introducing what this collaborative is, what our goals are, and then leave some time for questions at the end. Of course, drop them in the chat as we go, as they occur to you. So like a lot of other folks who have received this funding, our goal is looking at COVID-19 and the disproportionate impact that it has had on underserved populations across the state of Pennsylvania. Really, our three goals here are to improve health communication, reduce social isolation and loneliness, and increase access to technology. Now, you might notice each of these three goals addresses something that was an issue prior to COVID. COVID really just highlighted the deep inequities that already existed in these areas, especially for the areas of focus that we're looking at. Those populations for us are folks with disability, mental health concerns or psychiatric disabilities, and the aging. And I really just want to point out here the intentional overlap in the way that we're thinking about these groups. We know that these are intersectional identities, that they do not occur in silos, that folks belong to many communities simultaneously. And while our focus here is on these three areas, we are also very intentional about our outreach to folks in rural areas, to people of color, who we know when we bring in these pieces of experience, that the disparities are that much more compounded. So this COVID work has really allowed us to bring together an interesting group of people who often, were doing the health equity work prior to COVID, and people have just pivoted. They've shifted their focus to the health crisis at hand. But like Rachel had talked about, the goal with our work here is also to figure out how to continue this work beyond the pandemic. How do we make sure that the work going into improving health communication or reducing isolation continues and improves everyday lives beyond a public health emergency? So we have formalized this collaborative of several different people at Temple University. Kim and I are both associated with the Institute on Disabilities, which is the Pennsylvania's University Center of Excellence on Disabilities. But we've had the chance to reach across colleges. We're talking to people in the College of Public Health. We've brought in folks from the School of Social Work. We have faculty and staff from elsewhere in the College of Education and Human Development. So we've been able to build a lot of partnerships in ways that hadn't existed before. And I really want to point out our advisory board, which really oversees our work as a whole and is made up of a very diverse group of individuals from around the state who represent the focus populations that I mentioned earlier. These are folks who identify as self-advocates, who are providers or work for organizations who are doing work in this area. And right now we have about 12 folks, which is a really good size to get a lot of high quality feedback on the various aspects of our work. So we've met once, we're looking on growing just a little bit in the next couple of months, but we hope that our advisory board is very involved across all aspects of our work. Right now, a lot of it is in developmental stages, but as things shift into a lot of outreach, we'll be looking to them to help guide really targeted sort of recruitment of people to get involved in the programs that we're offering. How do we make sure that we are reaching people in those hard to reach areas? And having people from the community guiding that work is really critical to making sure that our work is community centered and community focused and has the intended impact. So I mentioned our three main objectives, and under each of those objectives, we have several projects going on. It's a big project and there are several pieces. So I'm going to give a brief overview of the types of things that we're doing, and then we'll spend a good chunk of our time hearing mostly about this program, Connect with Tech and increasing access to technology. But overall, our goal here is expanding support and services across the state, As I mentioned, we want to improve health messaging and communication. So we'll do that based on the beliefs, attitudes, and motivations of people with disabilities and aging adults through several projects. And then reducing social isolation. We're using a variety of methods to implement some programs or interventions that really look at increasing social connectedness. And that is targeting folks with disabilities, serious mental illness, and aging adults. So you sort of see we have, we're reaching each of our target populations in each of these objectives. And then lastly, we'll do our deep dive into increasing access to technology. So for improving health communication, a lot of these projects, as I mentioned, are in the development stages. A lot of planning involved to get the statewide reach that we're aiming for. We'll hold a lot of focus groups. We'll get a lot of qualitative input from communities around the state to help improve what accessible health communication looks like. How do we make sure that the messages resonate in the ways that they're intended to? So the first deliverable is to create a set of guidelines for how to create those messages and recommendations for the formats in which they are shared. The next project is using photo voice to collect and share personal stories and experiences of COVID, and using those personal messages to improve the communication between providers and care recipients. And then lastly is a health safety training. This is one of those things that was homegrown in the early pandemic. It was a training for people with autism spectrum disorders to learn how to follow those personal protective practices, wearing masks, washing hands, and it was really in the workplace. So how do we take that homegrown response to the pandemic and really refine it and make sure that it becomes an approach that can last beyond the pandemic? Just like Rachel said, we too are looking for ways to be preventative, to look forward, to have those long-term goals. And this is another example of that. So moving into our goal for reducing social isolation, these programs too are also really in the development stage with the creating manuals for the interventions themselves. But everybody who's been involved with that is using community input to refine the ways that these interventions will be delivered. But if this sounds like something that you might be interested in, when we are ready to start recruiting participants to take part in these interventions, let me know. I can drop my email in the chat, and we'll make sure that we include you in our outreach when we're ready to begin enrolling folks. But these are really both in-person and remote approaches to connecting folks and increasing those social relationships to reduce the impact of staying home and the inability to get out into your communities. And then lastly, access to technology and connect with tech. Kim can talk a little bit more about the homegrown nature of this and how we really responded to an intense need in the community and how it has evolved into a much bigger response. But our goal here is really running a statewide device and hotspot distribution program, increasing that access to technology, internet connectivity. And I'm really excited to have Kim today because this is the project that has really hit the ground running. I think the demand has been intense, and the ability of her team to respond to that has been admirable. So Kim, if you are ready, I'm happy, just let me know as we move through the slides, and we'll leave some time at the end to respond to questions either about our collaborative and also this project in particular.
You know, I actually did a program called You're Muted. Sorry about that. Hi, everybody. So Connect with Tech is truly kind of came out of, it was a reaction to the intensity of the need brought on by the immediate shutdown that happened in March of 2020. You know, Tech Owl is the statewide designated Assistive Technology Act program. And under Tech Owl, there's about 14 different programs. One of them is the Assistive Technology Act. We also do the free special, we administer the free special phone program statewide. We administer iCan Connect for people who have both hearing loss and vision loss, plus many other things, 3D fabrication, lots of other things. And the way we do our work across the Commonwealth is that we have 9 regional centers. We contract with Centers for Independent Living or UCP centers to engage in their local community all of the activities that we do in the Philadelphia area in kind of a webbed way. Our biggest things that we do are probably the Assistive Technology Lending Library, where people can borrow devices for up to 9 weeks to see if they would work for them. And so we're chugging along, we're doing our work, and the pandemic hits, and we look around, we're all now in our living rooms, we're meeting on Teams every morning, and we know that there's this huge need for people to stay connected with each other and for people to get connected, and that we needed to figure out a way on March 21st to address that need across the Commonwealth. Yeah, I know we have a fire in our belly about this stuff. And so we decided that, well, everybody's at home, and I'm sure people have old tech laying around that somebody else could use. We have a large reuse program as part of our assistive technology activities, where we gather gently used assistive technology, sanitize it, sterilize it, wipe it, clean it up, make sure it's useful, and then get it out to somebody who needs it. But all of our stuff was locked. We couldn't get to it. So knowing that there was this big need for connection, knowing that there was this need for actual devices, we thought, okay, well, we need to start there. Now, we all know that when you're talking about somebody being an effective user of of any kind of technology, if it is internet-based, you need 3 different things. You need the actual device. You also need a way to get connected to the internet. And you also need to know how to use the device when you get it. So we couldn't just do one without the other. Now, we have we had a network, a support network of helping people understand how to use the device. That's a big part of our work. And we knew that we were kind of weak in making sure people were connected, but we knew we could get people devices on March 21st, 2020. So we put out a call for people to send to our homes their used technology, which they did. We had an application for I Need Tech, and we have an application for I Can Give Tech. And our job was to make matches. And we did that in the first few months of the pandemic, and were able to connect well over 100 people in the Commonwealth. Now, that wasn't nearly enough. And then Aging came along with the first bunch of COVID money, and we partnered with them to get a lot of iPads and Chromebooks and hotspots into our lending library, because we already had the structure in place. And we just, by adding that inventory, we could get people connected that way. We have hundreds of iPads and Chromebooks and 100 hotspots. And we were getting that out to people, people with disabilities, people associated with people with disabilities, people who were aging into disability, elders, that kind of community. And we're listening to what people are saying and what people are needing. Well, the cool thing about the iPad lending project is that we own the iPads and we can push and pull apps to those iPads, even if the tablet isn't in front of us. So if somebody says, I have this iPad and I really need to get a grocery delivery app on it, we can push that from our office to the app and it will just show up for them. But people wanted to own them. And so I found myself saying, well, you might want to own a tablet, but you don't want to own this one because you can't do anything with it because it belongs to us. And we can't unhook it technically from the system. So then the Department of Health reached out to me and asked that we think about how we could help with a tech piece for the money that we are all spending now. And so I went to Sally and we figured out a way that the Institute could come together and do a multi-pronged response. So our commitment is to look at all three prongs of technology, which is the actual device, getting people the actual device that they own, making sure that they have a way to connect to the internet, and making sure that we have enough tech coaches around to support them as they do that. And over the next 2 years, we wanted our deliverable is for 5,000 households to be connected. There was great urgency in making that happen. So we spent a lot of time, we built a database, we created a system, we hired people. The trick was getting tablets. We all know about the shortage, and it took us a while to get the tablets, but I'm really, really happy with the work that we've done. And we did a soft opening, just started beta testing things at the first of the year. And by Martin Luther King Day, we were live. You can probably, do you have any of the slides with the data, Tay? I'm just talking, you know. So as of last week, we had 1,100 completed applications. As of today, I think I saw that there were 1,600 maybe, or close to 1,600. So you can see that things are moving along very quickly. One of our commitments to this program, or to the people of Pennsylvania, was that we get rid of as many barriers as possible. The free special phone program, some people might know it as TDVP, you have to upload a lot of information, and we saw that as a barrier. We also wanted to make it available to anybody who is at risk for health disparity. So this is the one piece that I hear where it's not specific. Well, I mean, the rural, I think you guys are looking at it kind of like I see it, which is anybody who's at risk for health disparity has access to this piece of the program. So if you identify as marginalized because of a couple of about 6 or 7 different areas, then you're eligible. And you just have to claim membership into one of the marginalized groups. You don't have to prove it. There's a couple reasons for that. One of them is I fundamentally believe that people don't want to screw people over, and that the amount of energy we put around setting up restrictions to make sure that doesn't happen is more than the little loss that we would get by just doing a more honor system. As of last week, we have a project manager who I believe is on this call. Shout out to Eli. And a graduate student. They have reviewed 741 applications. As of last week, 682 were found eligible and 59 were not found eligible. And then you should see this place, because then now we're getting, like, we have several thousand tablets here, and we had to find room for them. But a tablet, it's not just a tablet. that needs to be assembled, but the tablet needs to be put into the case. The tablet needs to be turned on, connected to the internet, and 2 icons for apps need to be placed onto the iPad. It's not an iPad. I'm sorry. Let me back up. This is not an iPad. It is an Android tablet, either a Lenovo or a Samsung. Thank you, Ted. It needs to be put in a case. We send with it a stylus. We also send with it a set of headphones. All of that needs to be assembled. And then our tech coaches and who are student workers send them out, make contact with the person who gets them, offer support if they need it, and ongoing support. Like some tech coaches are developing relationships with the people who've gotten the tablets. And other people, we ask in the application whether or not you have somebody that can provide support. Do you need support? If you need support, do you know somebody? If you don't know somebody, well, we can certainly be helpful, because we want to build in as many natural supports as we can. What's the next slide, Tay? So I just briefly looked last week to see where we were in terms of reaching the Commonwealth, and we have received applications and delivered devices. No, I don't know. We've received applications from 45 different counties. So we're getting there. Early on in the project, the student workers, we were waiting for the tablets to come. So they spent a lot of time creating basically a database of places that we could reach out to that were outside of the disability community that we were used to reaching out to. And that's how we've been getting the word out. We also have a very robust social media presence, and we've been using that to get the word out as well. And I just was curious to see what the racial makeup was, and what you see is 40% Black, 1% American Indian, 10% Asian, 7% multiracial, 5% preferred not to say, and 37% white. So is there any other slide? Oh, okay. So we're working with this absolutely fabulous organization called Generations Online. They do some really cool things. And these, when I referred to the icons that we're putting on the tablets, they developed this tutorial. And so you can also use it from a web browser. If you go to easytablethelp.org, you can see how it works, and it can absolutely teach people what a swipe means versus a tap. What, you know, it starts at a very, very concrete level and moves through to get people started on their own. Now, they also developed for the user, that's for the users. They also developed a vaccination location thing. For our tech coaches, we have a tech corner. This is actually just a website that our tech coaches use all the time. It's a public website. You can go to it and see what we have there. We are continuing to add to it. And there's specific instructions for each of the 2 tablet types that we have right now. Yeah, it's possible we'll have to get a third one if our resources dry up, and they will add that. So it's a work in progress. So I think I can open it up for questions. This is our flyer. It's easy to get to from techalpa.org, as is the online application. If somebody has a hard time filling out the online application, because imagine they don't have technology and we have an online application, they can call us up and we'll fill it out for them over the phone. Yeah, that's about it. I probably missed a whole bunch of points, but
well, I do think that we are able to share a flyer about the program with attendees after.
Great.
presentation today. So please, you're welcome to share widely within your own networks, because we still have tablets to send out. We want to make sure that it's getting out there.
Yeah, I will say that one of our glitches early on was that the way this flyer read, some people, mostly in the rural areas, felt like the way it read, we were saying that you had to be Black to get a tablet, and that was just a miscommunication or a misinterpretation of the language. So we changed that to hopefully make it easier too.
Thank you so much, Kim and Tay. That was a great presentation. We really appreciate it. As I said, we're going to open it up here for questions. See if there's anything. Just to let everyone know, we will be sharing the presentations and the recording with the attendees here in a few days after this. But so stay tuned for that. And then also they can include that flyer that you were just talking about today. Give it another 2 or 3 minutes here, anyone, see if there's any questions. In the meantime, do you guys want to pull down your presentation screen? And then if we don't get any questions here, I'll say by 10:11, we'll go ahead and invite Rachel back on to turn on her camera for a closing.
I'll just add while we're waiting for a couple of questions. I think that what's been great about increasing access to technology has been just seeing how it supports and relates to our other objectives in reducing health disparities, because we have seen just how critical that access to technology and connectivity to the internet impacts people's access to health information, and also their ability to connect socially with others. You know, we talk about access to technology and think about it in terms of telehealth, but it's also about reaching out to your family when you can't leave your home. And we're seeing all of these things come up through the pandemic. And I think it will really shift the way that we think about technology moving forward. We've seen drastic shifts in sort of the way we think about using technology and working from home in ways that we never really thought about before the pandemic, or never thought was possible. But we're seeing shifts there. And I think its role in responding to what we anticipate comes next. You know, a lot of folks are talking about this impending mental health crisis. We've been through a collective trauma. How are we going to respond to that? And, you know, the shifting way that we think about and talk about disability and how long COVID plays into that. There's so many things that are in flux that it's interesting to be in the middle of it. And I think that that's where we really look to people on the ground who are living it in the moment to help inform the work so that it is responsive. You know, our advisory board is helping us do that now. And I think as we develop more and more partnerships and really see how people are living through this around the state, we're able to tailor our response.
Thank you, Tay. Well, everyone, it is 10:11. So we did stop a little early here, but I just want to give a very big thank you to Rachel, Tay, and Kim for these wonderful presentations. They were very invaluable, and looking forward to collaborating further with these projects. Thank you so much for your time here this morning. We really appreciate it. Have a great rest of your day.